This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending in neurosurgery.
And I'm Dr. Alara, a research fellow. Today, we're looking at a fascinating new study from the Annals of Medicine, published in 2026, titled Association between Reduced Cervical Extensor Muscle Mass and Postoperative Outcomes After Single-Door Laminoplasty in Elderly Patients with Cervical Spondylotic Myelopathy, a retrospective study.
This is a timely topic, Alara. As our population ages, we are seeing more and more cervical spondylotic myelopathy, or CSM. It's actually the most common cause of spinal cord dysfunction in adults worldwide. We know that for patients with multi-level involvement and a positive K-line, posterior cervical open-door laminoplasty is often our preferred surgical approach.
Exactly. But while we focus a lot on the decompression itself, this paper reminds us that the envelope around the spine, the muscles, might be just as important. The authors specifically looked at sarcopenia, which is that age-related reduction in skeletal muscle mass, strength, and endurance.
Right. And as we've discussed in the OR, diagnosing sarcopenia in spine patients is tricky. You can't always ask a patient with severe myelopathy or chronic pain to do a grip strength test or a walk test accurately. So the researchers here used MRI-based muscle quality assessment.
They focused on fatty infiltration of the cervical extensor muscles. They reviewed 116 patients, but narrowed it down to 101 elderly patients, all over the age of 60, who underwent their first-time posterior single-door laminoplasty for multi-level CSM between 2015 and 2020.
And how did they categorize the muscle quality?
They used the Gaudier grading system on preoperative MRI. They looked at the extensor muscles and classified patients into 3 groups: mild, moderate, or severe fatty infiltration. To give our listeners the breakdown, 45 patients were in the mild group, 38 in the moderate, and 18 in the severe group.
It's a very practical way to look at it. If you're a resident looking at a T2-weighted axial image, you can see that white streaks of fat replacing the dark muscle belly. Now, let's get into the meat of the study, the perioperative results. What happened in the immediate postoperative period?
This was one of the first significant findings. The postoperative drainage volume was significantly higher in the moderate and severe groups. We're talking about 153.4 milliliters in the moderate group and 145 milliliters in the severe group, compared to only about 100 milliliters in the mild group.
That's a 50% increase in drainage. In an elderly patient, that's not insignificant. And I assume that translated to their time in the hospital.
It did. The study found that patients with more fatty infiltration had significantly longer hospital stays. It highlights that muscle quality isn't just about long-term recovery. It affects the immediate surgical stress and the body's ability to stabilize.
Let's talk long-term outcomes. We usually look at JOA scores, the Japanese Orthopedic Association scores, to track neurological recovery. What did the 12-month follow-up show?
The results for the severe group were quite sobering. At the 12-month mark, the severe fatty infiltration group had lower JOA scores, 11.95 compared to 14.69 in the mild group. But even more importantly, their JOA recovery rate was significantly lower, 55.9% versus 68.3%.
That's a major gap. As surgeons, we often tell patients that laminoplasty is great for stopping the progression of CSM and allowing for recovery. But if their muscle quality is poor, we might need to manage their expectations regarding just how much recovery they'll actually see. Did they look at the Neck Disability Index, or VAS, for pain?
They did. They found that the severe group had lower achievement of the Minimal Clinically Important Difference, or MCID, for both JOA and NDI. Essentially, patients with severe muscle wasting were less likely to feel a meaningful improvement in their daily lives.
That's a crucial point for our residents listening. When we talk about success in surgery, we aren't just looking at the MRIs to see if the cord is decompressed. We're looking at whether the patient feels better and can function better. If the cervical extensors are essentially replaced by fat, they can't support the head or assist in the rehabilitation process as effectively.
And that leads right into the radiographic outcomes, Dr. Aris. One of the most important aspects of posterior surgery is maintaining sagittal alignment. The paper looked at the C2-C7 Cobb angle.
This is a big one. Laminoplasty is known for the risk of postoperative kyphosis or loss of lordosis because we are disrupting the posterior elements. What did the study find regarding the relationship between the muscles and the Cobb angle?
The severe group showed a much greater loss of cervical lordosis. Their postoperative C2-C7 Cobb angle was 3.57 degrees, whereas the mild group maintained about 7.34 degrees. The author suggests that the reduced muscle mass essentially fails to provide the necessary tension band effect to maintain that lordotic curve after we've opened the lamina.
It makes sense. If the muscular stay wires of the neck are weak, the head drifts forward. This creates a vicious cycle. More strain on the remaining muscles, more pain, and potentially poor neurological outcomes because the cord doesn't drift back away from the anterior compressive elements as well in a kyphotic spine.
Precisely. The paper concludes that severe fatty infiltration is a clear predictor of poorer neurological recovery, prolonged hospitalization, and sagittal imbalance.
So how should this change our practice? For the medical students and residents listening, how do we use this?
The author suggests that preoperative MRI-based muscle quality assessment should be a standard part of risk stratification. If we see a Gautillier severe patient, we might need to adjust our surgical planning. Maybe we consider different levels, or maybe we are even more aggressive with postoperative physical therapy.
I agree. It also changes the preoperative conversation. For a patient in that severe group, I would be counseling them more extensively about the risk of losing their net curve and the fact that their recovery might be slower or less complete than someone with robust muscle mass.
It also brings up the idea of prehabilitation. If we can identify these patients early, perhaps there's a role for targeted extensor strengthening before they even hit the operating table, though obviously that's difficult when they are suffering from myelopathy.
True, but even postoperatively, knowing that the moderate and severe groups had more drainage and longer stays might lead us to be more cautious with drain management and early mobilization.
One thing I found interesting in the paper was the focus on the K-line. They mentioned that for patients with multi-level involvement and a positive K-line, this posterior approach is preferred. But this study adds a layer of nuance. It's not just the bones in the cord, it's the muscles.
It's the whole system. We sometimes get tunnel vision looking at the spinal canal diameter and the T2 signal changes in the cord. But this study is a great reminder that the cervical spine is a dynamic structure supported by a complex muscular system. If you ignore the muscles, you're only seeing half the picture.
Before we wrap up, let's recap the key numbers for the audience. Severe fatty infiltration led to a JOA recovery rate of about 56% compared to 68% in those with healthy muscles. Drainage was significantly higher, around 145 milliliters versus 100 milliliters, and the loss of lordosis was nearly double in the severe group.
High yield stats, Alara. This study really highlights that muscle quality is a prognostic indicator. It's a retrospective study, so there are limitations, but the association is quite strong.
It definitely sets the stage for prospective trials to see if improving muscle mass can actually change these outcomes.
Well, that's all the time we have for today. A big thank you to the authors of this study for shedding light on an often overlooked aspect of cervical surgery.
Thanks for joining us on the Neurosurgery Hub podcast. We'll link the full text of the study in the show notes.
Until next time, keep learning and keep operating. I'm Dr. Aris.
And I'm Dr. Alara. Goodbye, everyone.